The Harvard pen writes differently here. I noticed it on the first morning. The ink dries faster. The altitude, I think, or the dryness of the air at 3,840 meters. The paper has a slight warp from the humidity of the butter tea. I set the cup too close to the notebook. I have done this every morning for 4 months, and I have not moved the cup. The crack in the wall runs from the window frame to the ceiling. I have not repaired it. I had the thought on the second day, and then on the 14th, and then I stopped having the thought. The crack is still there. I am trying to write something. This is the desk. This is the notebook I bought at the departures hall in Kathmandu Airport. The spine broke somewhere around week 3. I have been writing in it since October, and whatever I am trying to write, I have not yet written it. There was a patient, Emma, 34 years old. She came in through emergency services on a Tuesday night in March 2019. She stayed 26 days. When she was discharged, I completed the discharge summary in my office at 11:15 p.m. The form has a field for outcome assessment. It has a field for prognosis. I wrote prognosis guarded in the prognosis field. I want to explain what that means. In clinical documentation, prognosis guarded is what a psychiatrist writes when the evidence does not support either optimism or pessimism in clear terms. When the honest answer is, I don't know, and the form requires something to be written in that space. It is not negligence. It is the language the field provides for uncertainty. I have used it on 14 discharge summaries in 31 years. Each of those 14 I remember specifically. I would call that a presenting complaint. Emma's session notes from week 2 contain a line I wrote immediately after the appointment. She had been describing a dissociative episode, the third she had reported that week. She said, I don't know whose thoughts these are. I wrote it down. Standard clinical practice. The patient's words, verbatim, in quotation marks, followed by the clinical notation. I still have the chart note. I came to Lo Manthang in October. The decision was made in August, which was 2 months after my 60th birthday dinner at the Harvard Faculty Club. There were 200 colleagues in attendance. 3 of my former residents gave speeches. The Associate Dean spoke. The words used, I remember them in their specific order: compassionate, visionary, the kind of psychiatrist who changes how we understand what this work is. He had prepared his remarks carefully. He had done me the courtesy of thinking about what the words should be. I thanked him. I moved to the next group. I ate the canapes. Someone made a comment about the salmon, and I said something appropriate about the salmon. DSM-5 code 300.6, depersonalization, derealization disorder. I co-authored part of the field trial data that produced those diagnostic criteria. Persistent detachment from one's own mental processes. The person experiences themselves as an outside observer of their own actions and thoughts. Reality testing remains intact. The patient knows what is happening. That specificity is important. The awareness is not impaired, only the participation. I had used those criteria on 23 patients in the decade since the field trial published. I could recite the diagnostic checklist in the correct sequence At the moment I was a subject of it, and the recitation was accurate, and the accuracy did not produce anything I could feel. I would call that a presenting complaint. I walked the Lo Manthang perimeter this morning, 23 minutes. The route runs inside the walled city, along the base of the outer walls, past the red ochre gompa and back to the tea house. The wind here does not stop. It does not vary its register based on what you need from it. The prayer flags on the rooftop above my room, I have counted them, 31 from my window. The number has no significance I can locate. I counted them the same way I have always counted things. In Boston, I counted days to the next conference. Here, I count prayer flags. Dr. Jonathan Reese was my supervisor at Yale. He's 68 now, retired from practice in 2020. He spent 30 years watching psychiatric training produce psychiatrists who were expert in emotional experience and personally impoverished in it. And he said something to me once, early 90s, I was still a resident, that I wrote down in a notebook very similar to this one. He said, "We teach containment as a skill. No one teaches you what happens to the container." I thought I understood it. There was a young surgeon, Patrick, who is now 52 and is the current director at MGH, the man who occupies the role I occupied for 14 years. Patrick came to me about 6 years ago with what appeared to be a clinical question. He had been describing his son's illness in sessions, using clinical language, presenting complaint, differential, treatment algorithm. His own son, 8 years old, a viral illness that complicated into something more serious. Patrick spoke about it the way he would have presented a case. I recognized it immediately as dissociation. I noted it. I gave him a referral. What I did not note anywhere was that I was doing the same thing in every session I conducted that year, converting experience into notation as a default mode. The language was accurate. The language was complete. The language was not mine. Here is what I have been trying to write at this desk since October. There is a field at the top of a discharge summary form. It says, patient name. There is a field for date of admission, a field for date of discharge, a field for attending psychiatrist. I have been sitting at this desk, in this room, at 3,840 meters altitude for 4 months, trying to fill in a field I cannot locate on the form. Not the patient name. I know the patient name. The field I am looking for is the one where the diagnosis goes. There was a woman, a patient from 2016. I will not name her. She came in for an intake in July, referred for mood disorder evaluation. In the first session, she mentioned, almost in passing, that she had been packing a suitcase for several weeks. Slowly, very deliberately, each item chosen with specific intention. She said she didn't know where she was going. She said the packing felt like the most honest thing she had done in years. I noted it in the clinical formulation as evidence of planning, which it was. I would call that a presenting complaint. I bought the notebook at a kiosk past security at Tribhuvan Airport. Departures Hall, Gate B side. I was late for boarding. On the flight from Kathmandu, I had connected through Doha. I opened it and began writing. I was writing what I thought was a list of what I needed to arrange when I arrived. I found, on the first page, something I had written without deciding to write. I turned to it this morning. I had not looked at it since I arrived. It is a discharge summary template, written in clinical longhand. All the fields: patient name, attending, admission date, discharge date, presenting complaint, diagnostic formulation, prognosis. The prognosis field is empty. I wrote this on the plane from Doha to Kathmandu. I did not know I had done it until this morning, 4 months later. In Emma's chart note, after the line, "I don't know whose thoughts these are," after my clinical notation, there is a treatment recommendation, specific, evidence-based, appropriate to the presentation. I wrote it at 11:15 p.m. It was correct. She said that. I wrote it down. I still have the chart note. The pen is running low. I have been writing with a controlled hand to preserve the ink, without deciding to do so. Professional reflex, the management of limited resources, the extension of what remains. The Harvard Medical School Faculty Excellence pen is on the coat I wear for the morning walk. I don't remove it. The people in Lo Manthang don't know what it is. A woman at the tea house asked me once, in Nepali, pointing at it. I said a word I had looked up, Puraskar, award. She nodded as if this explained something. I sit at the desk. I open the notebook to the field that has been empty for 4 months. Diagnosis unknown is a valid clinical notation. I have used it twice in 31 years. It is not the same as having no diagnosis. It is a finding. The uncertainty is the finding. It can be written. The wind comes through the crack in the wall. The prayer flags are moving. The Gampa is silent at this hour. Diagnosis unknown is what you write when you have conducted the full assessment, applied the appropriate criteria, and the presentation does not resolve into a clean formulation. It can be written. It is not failure. The field does not require more than what the evidence supports. I pick up the pen.